Well, I'm going to change pace a bit, and I'm going to be talking about pandemics and try to give you some detail about pandemic response from a national and an international basis. And as you will see in a few minutes, this really does serve as background for our working group recommendations, because you need to know what we can do and cannot do in terms of pandemic response, both in terms of the national response and the regional international response. So again, to remind you what I said earlier, not all pandemics are disasters, and I'm going to do two things. I'm going to introduce a disastrous pandemic, again, the 1918, the Spanish flu, the one you hear all the time as the classic disaster pandemic. And then I'm going to use as a case study the most recent pandemic, where we had lots of plans in place, and some worked and some didn't work. And I think we can use the response to the 2009 pandemic as a case study to help us in planning what we need to do going forward to be flexible, to be responsive, to be rapid in our reassessment of where we are and what we can and cannot do, what's important and what's not important. And in all of this, remember, the public must be involved. Not only does the public have to be involved, but we must have good communications. Because how does the public get involved? By knowing what's happening, what is possible, and what is not possible. Because they must know that we aren't magicians. We can't do everything. We can do the best we can given the information we have at a particular point. So, pandemics of the past have had different characteristics. Some have been disasters, some not. One of the issues that we had with the 2009 pandemic was severity was not part of the definition. And now this is one of the things you're going to hear in our recommendations. We have to develop better techniques for figuring out what is the likely outcome of a pandemic relatively early. This in the face of something which in the United States we were reminded over and over again. Presidential advisory groups trying to come up with an estimate of how bad the pandemic is going to be, and hearing voices, well, all pandemic viruses have got more severe over time. And it turned out that was not the case, and if we look back over history, it may have been the case once or twice, but not all the time. And specific decisions must be made early, and we'll talk about what we can do, what we have in our armamentarium, and decisions about this must be made early, which means that sometimes you're right and sometimes you're wrong, and you would like to be right and precise in what you plan for, but it's better to have more and not use them than to have less and have a disaster in your hands. And that is something which, looking back, you can be criticized for, but it is inevitable with any kind of disaster planning. You have to be ready for the worst case scenario, and you hope to fine-tune things, but it may not be possible. Okay, what do we have as our pillars of pandemic control? And we really haven't talked about this, but this again becomes part of our recommendations. And we have vaccines. And the problem with vaccines is they are specific to the virus that's causing the pandemic. We have limitations in what we can do for stockpiling, because we are not sure what the pandemic virus is going to be. We had stockpiles in the U.S. for avian flu, and we got H1N1. So we had to start from scratch in producing a vaccine, which is specific and the best kind of prophylaxis prevention of a pandemic. We've got to learn how to do better surveillance and to get the virus earlier so we can get the vaccine earlier. We've got to be able to produce it more quickly. Antivirals, that we can stockpile, because antivirals are not specific to the particular virus. But then you have to figure out how much to have. And every country made different decisions about how much to have. And then in the U.S., we were worried about using it up, so we probably underused antivirals. Other countries, such as Japan and the UK, used a lot more antivirals. And we may or may not have had a good effect. Now, non-pharmaceutical interventions, we don't hear a whole lot about because we don't use them with seasonal influenza. And I'll go into specifics here because all countries can use non-pharmaceutical interventions, closing schools, keeping people who are sick home, away from the population, closing down the transportation net if it really becomes bad. This is something to consider. And this is where you really need to know how bad the pandemic is going to be, because you don't want to make a bad situation worse if the pandemic is a mild one or a moderate one. Only when you have a severe pandemic do you want to get into these issues. So let's go into some specifics. Let's look again at the mother of all pandemics, and we know it goes through the population fast. We have to be able to respond quickly, and that's why being able to identify severity early is important. Now, these are actual numbers from the city of Philadelphia, and these are annualized deaths. And I checked this out because I couldn't believe it the first time I looked at this. In 1 week, if deaths had continued over a year, 140 per thousand, 140 per thousand deaths occurred. That wasn't the number in that particular week, but if it had continued, these are annualized numbers, that would have been the case. An absolute disaster. The mayor of Philadelphia, because they had some meetings before that, and they were blamed the mayor. You've got to blame somebody. So they blamed the mayor, and he was actually taken to court and accused of manslaughter or murder because he had not closed things down, and this is what happened in the city of Philadelphia. And non-pharmaceutical interventions were used. Here are policemen wearing masks, public messages. All this happened in 1918, unplanned. What we try to do now is to plan this and to organize it, because it will happen if a pandemic is bad. This is called, this is one of the non-pharmaceutical interventions in which we try to keep people away from each other, churches, schools, shows closed. And this will happen if we have a severe pandemic. It's better to plan in advance, and if we think these events, these actions have a purpose, to put them into effect early when they can do something rather than late where they may look like they're doing something because the epidemic is improving anyway. And that's one of the problems in trying to figure out how well these interventions work. Avian influenza started our planning. It was moving along slowly in the 1990s, but it was the emergence of avian influenza that really got us going. So the blessing was we got going. The curse was that we expected, or many countries expected, the pandemic to be severe, and it wasn't. So the plans had to be retooled. And again, I've shown this to you before. Why is avian influenza so worrisome? Because of the case fatality, the number of people who are sick who die. Remember that? Case fatality, I'll bring it up again. The percent of those who are sick who died. Okay, preparing for the pandemic. This is for non-pharmaceutical interventions, community strategies, and look at all the different U.S. agencies that had to sign off, all of those logos at the bottom. So all of these agencies had, and this is in one country. This isn't international collaboration. This is in one country. And this is producing something which is more or less a logical plan. It's not rocket science. It's taking things that you know that you need to do or need to think about and putting them in an organized strategy. And everything in this strategy was based on severity. And what kind of indicator was used? Well, this happened after Hurricane Katrina. And in hurricanes, we have 5 categories. So the decision was we'd go with something the public was familiar with. 5 categories of severity, and these were based on case fatality. What proportion of those who were sick died? And 1918 was sort of category 4 to 5. Remember I said that if 1918 had occurred now, it would kill about close to 2 million people in the United States. So that's where category 1918 goes. The 1957, 1968 are down around category 2. But all of this is based on the proportion of people who are sick who die. Nobody thought that we would see something like the 2009 pandemic, where older people, who are the main people who die during a pandemic, would be relatively unaffected. Number one. Number two, nobody really gave thought to how do you estimate the number of cases? How do you determine case fatality if you don't know the denominator, the number of people who are sick? How do you estimate the numerator, especially if you hear reports from Mexico that people are dying, but you aren't even sure what they're dying of? So, as I'm going to remind you, we never use the categories. And here, this is from the report, which you can consult. All of the non-pharmaceutical interventions are categorized by whether they're recommended or not based on severity. Beautifully worked out plan, great deal of logic, not a whole lot of total buy-in from everybody, because the question is, if you close schools, where do the kids go? Do they go home and stay away from other kids, social distancing, or do they all congregate in the mall and still transmit virus one to another? So this was part of the problem in the decision making. Here's more of the kinds of recommendations that were made. Now, what happened on an international basis? And you'll hear about the international health regulations again when you hear our report. And this was really important that we had the new international health regulations in place. Now, what happened before the pandemic, and I'm going into this because there's a lot of misinformation that has appeared in the media, especially in Europe, about everything being changed in 2009 after the pandemic occurred so that it could be called a pandemic. And that really was not the case. Severity was never part of the WHO definition of a pandemic. And what happened in 2009 was a modest change in what are called phases on the international level. And phases simply refer to the extent of spread of the virus. And the big change was in phase number 4. And in phase number 4, and all of this was based on the avian flu scenario, expecting that you'd see small outbreaks of avian flu and it wouldn't go anywhere. And then all of a sudden, things would start to transmit. The virus would start to transmit. And you would have a little time to try to contain spread of the virus. And phase 4 was considered a critical point because that's where you try to contain. And the assumption was that this was going to occur perhaps in Southeast Asia. And then when we got the pandemic, we got it next door to us in Mexico. So everything had to change in terms of timing. So this is where you consider switching to the new pandemic vaccine. So this is where we were in 2009 when the pandemic hit. And what happened in terms of WHO and recommendations? On April the 25th, the international health regulations were invoked by an emergency committee advising the Director General, declaring a public health emergency of international concern. That invokes certain items in the international health regulations which start the march towards declaring a pandemic, mobilize the international community. We went very fast because, in fact, everything was gone. The genie was out of the box in terms of the spread. And we went very fast to phase 5 on April 29th. But then we had a long pause before declaring phase 6, which is the pandemic phase. Phase 5 means transmission in 2 countries in 1 WHO region, which clearly was the US and Canada and Mexico at this point. There was a delay going to phase 6, which said involvement of another WHO region. And we all knew that really phase 6 was occurring. And what was happening during this period? Many countries that had tied their pandemic plans to the avian scenario, the severe scenario, were getting their act together in terms of not having to close borders, not having to do various things necessary. While this all was going on as well, countries were arranging to get vaccines. We've got our vaccine, and Professor Webster will undoubtedly tell you the importance of surveillance in getting the virus quickly. We didn't get it quickly enough, which is another lesson learned. So in this time, many countries, not knowing how severe the pandemic was going to be, were getting their orders in for vaccines, antivirals. You either have them or don't have them. You can't really produce them fast enough to change the amount you have. Okay, the early U.S. response, and I'll go through this quickly. I think all of you are familiar with this. I'll make only 1 or 2 points, and one was that we were closing schools, and it was illogical in terms of recommendations that changed. It was mainly not for containment. It was because of political necessity. When you have 40% of kids out of a school and don't know what to do, you have to do something. And the decision was made to move the vaccine ahead. Now, what happened, again, many people say this was not a severe pandemic. It depends where you were. We had many deaths in young children, and we had, while about 30% of our population got sick, and that's expected, not all illnesses are mild. But I'd like to just point out one thing. If you look at deaths, you will see that most of the deaths occurred in the 18 to 64 age group, many without underlying conditions. So this pandemic, the shape was totally different from what we had experienced before. It almost was, people were saying, oh, it's like 1918, where most of the deaths were in healthy adults. Well, yes and no. It was like 1918 in that regard, but certainly it was a lot milder. Now, the whole pandemic response has been reviewed by an advisory committee to the Director General, and this is the URL. And this is something that should be looked at. We're going to refer to this in our response, in our working group response. But a lot of these recommendations for what to do going forward have been made. So as I've said, we've got to be sure that we know severity. We need communications, prior planning, but we have to be able to be nimble, to be able to change, to be able to be sure that our response is appropriate. And again, I always preach about seasonal influenza being there and probably killing more people over a few years than a pandemic does in a single year. We can test our plans against seasonal influenza. Thank you.